Hello and good evening, good afternoon to some, good morning to others across the globe. We'd like to welcome you to our Vascular Ultrasound Master Class today. For those joining by the web, I would ask you to go to paulev.com, enter DeBakey, and respond to the activity. For those joining us by text, you can text DeBakey to 37607 and text in your message or questions during this 1 hour presentation. I hope that today we're going to be able to discuss and cover as much as we can material related to the interpretation of upper and lower extremity venous duplex ultrasound studies. We're going to start with the basics of when to order an ultrasound of the upper extremities and then lower extremities, and as we're going through this, through the motions, we'll cover plenty of examples and cases during our presentation today. And please feel free to send us questions, and we'll try to answer them live or during the end of the presentation today. So let's start with venous duplex ultrasound. For all of those who are familiar with this, the anatomy of the upper extremity is quite simple. We have the central veins, we have the which include the subclavian and innominate veins. Axillary vein, brachial vein, the superficial veins will include the basilic vein and the cephalic vein in the upper arm, and also basilic vein, cephalic vein in the forearms. Common indications for the performance of upper extremity venous duplex imaging includes limb swelling, limb pain, tenderness, oftentimes to document for a source of a pulmonary embolus, and other studies such as also upper extremity vein mapping for the implementation or creation of arteriovenous access in hemodialysis patients. The way we perform ultrasounds of the upper extremities, usually we'd like to have a linear transducer, 5 to 7 megahertz. However, at times, depending on patient's body habitus, we may want to decrease the frequency to 2 to 5 megahertz and use the curved transducer to get deeper, especially if we're trying to image the subclavian or vein, or sometimes the axillary vein, the axillum, somebody who is who has a large body habitus. For more superficial veins, if you're looking at the more superficial veins, such as the basilic or more likely a cephalic vein, and we're concerned, especially in somebody who's very thin, we may want to consider a higher frequency transducer, 10, 12, up to 15 megahertz, to look at the more superficial structures. The response to augmentation is less reliable in the upper extremity as compared to the lower extremity. We're going to go over this once we discuss the lower extremity. There's also marked variability in spectral waveforms that mimic arterial signals, especially in the more central veins, like the jugular, the proximal subclavian veins. Normally there's a pulsatility that we notice in the upper extremity vein, especially in the jugular vein, the proximal subclavian vein, that does expand to the more peripheral veins, but usually reaches the axillary vein and not the superficial veins. Why is this? Well, this is very simple. As you see in this image here, we have, this is an image of one of our central veins, and what we see here is that there's a typical pulsatility that will appear usually in the jugular or the subclavian vein. There's a forward flow that occurs, and this is sort of a brisk forward flow that we see here, okay? And this is the flow that occurs as the blood is moving towards the atrium. So this causes a sharp increase in forward flow of venous blood. As the atrium fills, that forward flow that we see here tends to decrease, and as the ventricle begins to contract, some of the blood in the atrium can flow retrograde, and these are the spikes that we see above the baseline usually. And this is normal in the upper extremities. In the lower extremities, this can be potentially a normal finding, but sometimes it can be pathological. We're going to go into more detail once we get to the lower extremities. If you look at this wave from the jugular vein, it lacks that sort of up and down or seesaw appearance. And this denotes an evidence of obstruction more centrally in the jugular vein, or as it joins the subclavian vein, or potentially in the innominate vein. But this certainly, as you compare these two images, you know, this is what's going to be normal in the jugular vein. This is going to be an abnormal waveform in the jugular vein, which is a continuous waveform. Loss of pulsatility, especially if unilateral, suggests a central venous obstruction, most often at that segment, either the jugular, the subclavian, the innominate vein, and so on. If it's bilateral, it could be potentially in the innominate veins or brachiocephalic veins and or the superior vena cava, again, and more central. Here's an interesting example. As you see here, there's a phasicity, or there's a seesaw-like appearance in the more proximal subclavian vein. In the same patient, as we go past the clavicle, we see that the waveform becomes a little more continuous. This is in the axillary and the subclavian vein, and what we see here is that this is a patient with venous thoracic outlet compression of the subclavian vein between the first rib and the clavicle. Okay? An interesting maneuver is called the Sniff test. This is a little bit hard to sometimes perform, but it gives us an indirect evidence that the central venous system is patent. What happens is, as the patient takes a sniff, or a very brisk or rapid inspiratory effort, almost like the stalling forces, the vein tends to collapse as the increase in flow occurs, and if the vein is able to collapse or it decreases in diameter, we can assume indirectly that the central venous system is patent. Sometimes this test is not very reliable, especially in patients who may have a central obstruction, but they have developed enough chronic collaterals. But this is one more test or a technique that we'll have in our armamentarium. Here, for example, is an example of a clot in the jugular vein. Notice the jugular vein is dilated. It's a partial clot. There is no surrounding edema in this instance. And the question is this a subacute or acute thrombosis? Here's an example of a chronic thrombus. This vein is small in caliber. The vein wall is thickened at one segment where it's patent, but more proximally here it's completely occluded. And the thrombus is almost isoechoic, meaning almost the same color as the surrounding tissues, and this denotes a very chronic thrombus or episode. Here's another example. There's a chronic clot that is attached to anterior wall of the jugular vein, but it seems to be separated from the posterior and medial walls of that vein. Here's an example of basilic vein thrombus. Here I'm trying to connote that this vein is being compressed and it's not compressible. And here we see a segment, it's not fully compressible. Here we see a segment also of a partial basilic vein thrombus, just a small amount of clot that's visible at the posterior edge of the vein. So here's another example of interesting findings in the upper extremity. This is the cephalic vein. If you look at the spectral window, it's a low window 8 measured at 8 here, and we see significant disturbed flow within the cephalic vein and very sort of pulsatile arterialized-like waveforms, even though the velocities are not extremely high. They're only 40 centimeters per second. But these waveforms are arterialized along with a disturbed flow and spectral broadening. We can assume here that there's an incidental arteriovenous fistula detected in that vein, probably from a previous intervention or peripheral IV, etc. Now, here's another example. This is an example where the flow appears arterial in nature, but look at the velocities. The velocities are low. They're between 5 and 10 centimeters per second. So all we need to do here is adjust our knobs to get a better appearing venous waveform, but this is not an arteriovenous fistula, even though it has this kind of pulsatility. The velocities are very low, and there's no spectral broadening or turbulent flow. So when we look at the veins, what can we do? How can we analyze the veins? And this table is actually, it's a nice table because it gives you different things that you can look for to be able to characterize whether the vein is patent or not, and to try to study the vascular flow through those veins. And this encompasses compression of the vein, looking for flow within the vein, and looking also at the echogenicity of the vein or of its contents if there is a thrombosis. And as you see, wherever there isn't a bony prominence, we can perform compression. Here in brachiocephalic, of course, it's behind the sternum and in the ribs, so we can't compress. We can compress certainly parts of the subclavian vein, but not all parts of the subclavian vein, as it courses under the clavicle. But we can look at flow, mostly for most, and also the echogenicity, except for the veins that we cannot analyze. That's why the brachiocephalic vein, usually by ultrasound, we can get a lot of indirect information by looking at the jugular, at the subclavian vein, and trying to characterize the waveforms. The common indication now for lower extremity venous swelling is also varied. And I'm not going to go through all the vascular indications or the clinical indications for ultrasound, but I can definitely summarize them into three major things. We're looking for lower extremity vein mapping. We're trying to look at the size of the veins to evaluate those veins for potential use as a vascular conduit. We like to look at the lower extremities to look for commonly deep vein thrombosis. Of course, we can look for vascular malformations, etc., and also for the evaluation of venous insufficiency. So these are the three main reasons why we're performing venous duplex ultrasound of the lower extremities, among the others that we discussed. So how do we place the patient? Usually we want to do this procedure with the patient either standing or in the reverse Trendelenburg, head up, feet down at about 15 degrees. And make sure also that the room is not cold. You don't want to expose the extremities until you're ready to do the ultrasound, because remember, a cold room will cause some vasoconstriction, and then you may lose some of the clues within the study. And especially in the lower legs, you want to keep the legs slightly externally rotated and in a relaxed fashion in order to be able to access the calf in case you need to perform compression. Again, we use a 5 to 7 megahertz transducer. For the deeper structures, you need to decrease the frequency to anywhere between 2 and 5. And for more superficial veins, you may want to increase the frequency 10 to 15 megahertz. So what do we look for in the venous study? We look for spontaneity. We look for phasicity. We look for augmentation of venous flow with either compression or Valsalva maneuver. We look for pulsatility of that venous flow, or if the waveforms appear arterialized, we look for patency of the vessel. And how do we look for all these things? Well, we do compression of the vein. We look for color Doppler within the conduit, and for also Doppler waveforms. So let's start with the simple part. Lower extremity vein mapping. We look at we try to measure the diameter of the vein, and usually we want to measure it the same way every time, anterior to posterior wall. And this will have to perform it almost in a consistent manner so that you're able to reproduce, and then that your results are being trusted by the person who's eventually reading the test or who's using that test to make a clinical decision. Here's one of those examples where we have our saphenous vein, and we are measuring the anterior to posterior wall diameter. Sometimes, as an important point, sometimes we like to use a tourniquet if we can, like a rubber band, to be able to increase the size, but ideally having the patient in the standing position may be the best way to perform this, or potentially at a 15-degree reverse Trendelenburg. And here's an example of such measurements where we're able to get the measurements done and tabulate them in the chart in a very clean and consistent way, as we can see here in the table. Here they have anterior accessory vein that appears very prominent. It's been drawn and diameters have been included. How about venous duplex ultrasound for DVT? Certainly this is an important test to perform. It's one of the most common tests that we do for the lower extremities, especially nowadays with the COVID pandemic. A lot of patients are presenting with venous thrombosis, and the studies have been very important. One important caveat here is if we're doing an ultrasound of one leg, a unilateral leg, we always want to make sure we image the corresponding contralateral femoral vein, because comparing those waveforms is extremely, extremely important. I'm going to give you some examples of that. Especially when we're going down the vein and we're imaging, we want to do compressions almost every 2 centimeters. This could be something done very quick. Doesn't take forever time, but the closer the compressions you perform, the more reliable your test, because you don't want to miss a focal thrombosis that may be present. And one important thing sometimes, and it's maybe useful for clinicians, is for us to be able to try to differentiate between partially or totally compressible segments. And if we can, in a way, if we can try to age the thrombus by, trying to name the thrombus as something acute or something chronic, because this will really help tailor further clinical management of these patients. In addition, if you find any other abnormal structures, a seroma, a hematoma, a pseudoaneurysm, a Baker's cyst, etc., it's important to identify the structure, label its location, and take measurements of such structure. Here's an example of a normal venous duplex ultrasound. What we see, there's no compression. This is the femoral vein. It's nice, widely open. I call this the Mickey Mouse sign, where you have the saphenous vein coming off, saphenofemoral junction, femoral vein, and this is the common femoral artery. And here we're compressing the vein, and that's a normal compression. Here, no compression. We see the vein, it's dilated. It has echogenic material inside of it. And then when we compress it, nothing happens. So this is a thrombus. This does not appear as a chronic thrombosis. You see this white petechia inside, these kind of marks. So this tells us that it's at least a subacute or a non-acute thrombus. Here's another example. Here's the vein where it's open without compression. With compression, we see this sort of shelving edge. And this is a hyperechoic old chronic thrombus on the anterior wall of that femoral vein. Here's an example of a deep vein thrombosis. First of all, it's not really attached to the wall yet. There's a hypoechoic center with some hyperechoic or isoechoic margins. Perhaps some mixed echogenicity. So this is more consistent with an acute or semi-subacute deep vein thrombosis and not in a chronic thrombosis. Here's an example of chronic and partial deep vein thrombosis, and we know this because of the history, and this was a follow-up ultrasound, and you see the hyperacute margins, you see the thrombus, it's slightly attached to certain areas, it looks almost like a small tongue coming up towards the vein. And you see that there's color flow, and there are also waveforms present consistent with a partial thrombosis. Here's another example of a deep vein thrombosis, and what we see here is interesting. It's a dual system, okay? You see the femoral artery and a duplicate femoral vein up here. The bottom vein here with compression, it partially compresses, but it still, it remains almost non-compressed as compared to the top portion of the femoral vein, which is compressible. So we need to be careful here because, one vein may be thrombosed and the other one may be patent, and that's very important to also identify. Here's another example of a partial thrombosis or recanalization, in this case as a chronic area of the femoral vein, and then there's the sort of a linear chronic thrombus noted. And this is just sort of looking or trying to define what anechoic is for those new in ultrasound and what sort of a hypoechoic area looks like, and the isoechoic segment, which will be up there. Here's again another example of a duplicate popliteal vein. And what we see is that one of the two veins has partial clot. You see this area here. And if you look at the appearance of the thrombus, it appears somewhat acute in nature. This is something we're going to come across quite a lot, not necessarily a thrombus, hopefully, but evaluating patients after saphenous vein ablation, which has become a very common procedure. And what we want to do is try to define the class of thrombus, if present, abutting into the common femoral vein, because this will also have some implications for clinical management. Class 1 is when you have the thrombus in the saphenous vein or the ablation reaching all the way up to the saphenofemoral junction. Class 2 is when you have less than 50% of that thrombus extending into the common femoral vein or past the saphenofemoral junction. Here you have more than 50% extending into the common femoral vein. And the class 4 is when you have essentially deep vein thrombosis, for the common femoral vein is almost completely filled with thrombus at that site. Something we see quite a lot is also viscous flow, and what you see is this sort of you can almost see the red cells in a way as they're flowing through. Sometimes it's just a matter of adjusting your knobs, but if we're able to see sort of the viscous flow of blood going through, this has several implications. Some of those can be dehydration. It could be increased blood viscosity in patients with malignancy. It could include cardiac pump dysfunction, somebody with a low EF or heart failure, or just a low flow state in somebody who's potentially hypotensive, dehydrated, etc. This is an interesting example. What we see here is a vein completely patent, and what we see here is the valve in the popliteal vein, and you see just a small amount of thrombus right behind the valve leaflet. On the active images, this was almost like a very thickened viscous flow. You could see this kind of swirl around, okay? So this really certainly it's a setup for deep vein thrombosis. Color Doppler is important, and we got to know how to use our knobs. Spectral Doppler waveforms should accurately demonstrate the venous flow characteristics, spontaneity, physicity, flow augmentation, and pulsatility. So these two, color Doppler and spectral Doppler waveforms, are very important when evaluating the venous system and also for determining patency. So let's look at the spontaneous flow of blood in the lower extremity. There's some phasicity, unlike the upper extremity. Remember, where you had the sort of seesaw, which was a normal finding. The seesaw is not necessarily, and I say necessarily with a little caveat here and there, because it can be normal, especially in the young patients. But there are some characteristics that may suggest potentially some valvular disease, and we'll talk about those. So this is normal waveform for the femoral vein. There's augmentation, meaning somebody squeezes the calf or the thigh, you get increase in flow, and you don't necessarily go above the baseline, not significant reflux, and it goes back down. And same thing here. Remember, there's normal flow, there's augmentation here. This is somebody squeezing the thigh or the calf, and then you get return to normal flow. Again, let's go back to more normal waveforms. Important to know what normal looks like. This is normal. There's a little augmentation perhaps. There's some augmentation here, but this is normal phasic flow. Now we start seeing a little bit of decreased phasicity. This is in the same patient. This is why it's important to compare the right side and the left side. You see on the left side how you see some phasicity and there's some waxing and waning of the flow here. You know, so does this suggest potentially a more central venous outflow stenosis in the iliac system? Potentially, but let's look at something that's more obvious. So this is pulsatile flow. Pulsatile flow in the lower extremity. So the presence of pulsatile flow in the lower limb should alert the sonographer that there could be, not necessarily, but there could be a pathologic condition. Okay? And what happens here is dilatation of the vena cava in the iliac veins that occurs in right-sided cardiac dysfunction or tricuspid regurgitation facilitates and speeds up the transmission of the right-sided atrial pressures, and the waveforms may appear pulsatile in the lower extremities. I find that this correlates more in older patients as compared to the younger patients in general. So this is the same patient, right leg, left leg. Well, we should expect to see the same pulsatile flow on the right leg. And the fact that this flow does augment, but it's mostly continuous. If we had not augmented the flow with compression of the calf here, the flow would be more generally continuous there. So this tells us there's an outflow venous stenosis on that iliac vein. Again, another example. Notice, this is the right side. Very pulsatile flow. Left side continues, almost a straight line. Could this be May-Thurner? Could this be iliac vein occlusion, etc.? Well, certainly you're now suspicious of this and you get indirect evidence of central venous outflow stenosis. So let's kind of summarize briefly. Talk about acute DVT. The thrombus usually is hypoechoic and the vein is large or dilated. And usually, veins are usually about the size or larger than their arteries. Usually my rule of thumb is if the vein is much larger than the artery and I consider that dilated when you have thrombus inside, and that may potentially, again, it comes with seeing a lot of ultrasounds, suggest that this is more of an acute thrombus. Direct criteria for thrombosis: inability to compress the vein. Whether you compress it all the way, that's patent probably, or more likely. partially, or you cannot compress the vein at all. That's certainly a direct criteria of a thrombus. Another direct criteria is absence of waveforms and or color flow. The problem with the waveforms is you really need to get your windows down. You cannot have your windows at 30 for your color. You got to bring that down to less than 10, 8, as low as possible, especially in patients who may be slightly dehydrated, etc. And remember, if you have a deep vein thrombosis, you may not have enough flow, and you want to try to determine, is this partial or not? For a chronic DVT, the thrombus may be isoechoic or hyperechoic. Isoechoic may potentially be subacute to chronic. Hyperechoic is more likely a chronic thrombus. And the veins usually are, especially with very chronic thrombosis, the veins are usually very small or smaller usually than the corresponding adjacent artery, and the veins are usually not dilated. Indirect criteria of thrombosis, well, loss of phasicity as we showed in the femoral veins by suggesting a more proximal venous outflow stenosis or occlusion, and continuous waveforms or flow during Valsalva or doing compression. So when you try to augment and you don't get that flow that you're looking for, then that may be a indirect criteria. I'm going to talk about examples with augmentation, because what happens with augmentation is very, very important. If you have your probe in the common femoral vein and you compress the calf, and you do not get that increase in velocity with the waveform dipping, that may potentially suggest that there's an obstruction between your probe and the area of compression. And that is very important. We're going to give some examples. I guess this is one of those examples, yeah. So here there's continuous flow in the femoral vein on the right side compared to the left side. Notice how it's phasic. So we know that at least there's a venous outflow stenosis in that iliac system. What happens? We keep the probe in the femoral, we compress in the calf, we get augmentation of flow, but then we get a little bit over the baseline and back down. So this tells me that, yes, there is an iliac vein obstruction, maybe a stenosis, maybe a thrombus, but it's partial because we were able to get a little bit of that reflux to show. Non-significant reflux, but yet it's present. So that is a very important clue that we get by just looking at the waveforms and performing certain maneuvers. Again, here's another patient with pulsatile flow. Okay, we noticed sort of the seesaw-like appearance, especially where this goes above the baseline and it mimics the EKG. And then here we have a respiratory phasicity. This is just variations with respiration, there's augmentation, and certain variation with respiration. So this is not pulsatile flow, this here is pulsatile flow. Let's look at this. Here's a patient, and remember, we talked about kind of doing compressions every 2 centimeters. Here we're not doing compression, but we're being very careful and looking at the spectra, the color spectrum. And what we see here is that there's this quite interesting disturbed flow right in that very proximal saphenous vein, saphenofemoral junction, and we look at the waveforms and look at these waveforms. They're disturbed, they're arterialized, velocities are slightly elevated. So this points to a very focal arteriovenous fistula, probably as a result of a venous puncture attempt or a attempt at catheterization of the artery, etc. Here what we see again, disturbed flow in the vein. This is the common femoral vein, okay? And here's another example where we see also arterialized flow, and there's the little connection between the femoral artery and the femoral vein, and there's a small fistula present. Here's another example. There are phasic waveforms on the right side. On the left side, velocities are increased. This is shifted from the baseline. And as we go down the femoral vein, you see that there's some arterialized flow. And as we get down to the popliteal vein, and we're able to identify the segment on the artery where the arteriovenous fistula to the popliteal vein has occurred. And this is quite an interesting finding. This is a patient with some lower extremity swelling on the left. Here's an interesting patient with a proximal great saphenous vein aneurysm. So this is the saphenofemoral junction. The saphenofemoral junction is quite generous, and we see that there is reflux with augmentation. And we see the saphenous vein up here, and then you see a dilated, very generous saphenous vein. This is a great picture. I love this. You see the valve leaflets. You see how the valve leaflets are not touching. The vein has dilated enough that the valve leaflets at the saphenofemoral junction have separated, and they're not able to close. And there is partial thrombus here present in the dilated saphenous vein. The patient underwent excision of that segment of saphenous vein. So this is a patient who had a history of successful left great saphenous vein ablation. This is about 5 to 7 years later, and what we see here is some neovascularization right at the in the groin area. And this is a patient with some recurrence of varicose veins in the lower legs, but this is what neovascularization will look like. We see that sometimes after saphenous vein ablation. We also see it after stripping, especially not infrequently. This is another example, as we talked earlier, of a duplicate femoral vein. You see femoral vein. This is the femoral, superficial femoral artery. And we see, we're just confirming that there is patency of that system. Here is, again, a valve, and it's always, I find it always fascinating looking at the valves, especially in these with pictures. And here's an example when we're looking at the lower extremity. We really want to also identify the tibial veins, and in this case the posterior tibial vein. We always look for a paired vein. Sometimes you may have a thrombosis in one or the other, if not necessarily both. This is courtesy of Dr. Zol Garami. I love this picture. I don't think I would have ever caught this, but what we see here is a microembolic signal. This is a patient with sickle cell disease who came in and was having some issues. The patient had a small pulmonary embolus, I believe, and on the ultrasound they didn't discover any significant major deep vein thrombosis, but during scanning he was able to catch this microembolic signal there, suggestive of a remnant of some thrombus still present in one of the vessels in the lower legs. And this is quite interesting. I've never seen that before, but it was one of those things I thought I'd share with you guys. Here's another patient, again, acute DVT of the right leg. If you look at the thrombus is it's not bright white, which tells us that this is more of an acute event. The vein is dilated and it's adherent to the anterior wall, but sort of separate from the posterior wall, which is partial, but this is almost a complete partial, maybe 80–90%. And again, the way we tabulate these things in our reports are usually, we have a table which is visually easily noticeable, and we can look for deep vein thrombosis. We talk about ablation, and we can characterize the various elements of our study. This is one of those classic venous duplex ultrasound reports. In this case, this is a normal report, but if you look at the reports, visually, you look at the table, within 2 to 3 seconds, you almost have the answer. Is there a thrombosis or not? And then there's the description, and this is the important part where you're able to discuss what you see, if there's an abnormality or not. So let's take a look at venous insufficiency and evaluation for reflux. So this is sort of a sequence. We have the flow in the femoral vein, and this is the patient here performing a very gentle Valsalva. You see a little bit of reflux up here, and then the flow returns back to normal up here. So flow is antegrating the vein. There's a little bit of reflux back, but it's minimal. I mean, non-significant, but it's physiologic. And then as the blood flow starts to return again back to its baseline forward flow, you see here that the flow returns back to baseline. So a complete test for venous reflux includes vein mapping and duplex ultrasound with compression and waveforms. Waveforms are essential. One of the prevailing theories for pathogenesis of varicose vein is that valvular reflux is one of those culprits, and especially if it involves the superficial venous system, which leads to the tributaries usually arising from the great saphenous vein to become dilated and varicose. There are, of course, multiple factors that lead to varicose veins, including genetics and biochemical changes in the vein. So for a reflux study, we need to make sure that patients get evaluated for deep vein thrombosis, and usually we get these reflux studies in patients who have post-thrombotic changes, previous DVTs, and want to figure out what's happening in their venous system. Usually we perform these studies in the standing position or reverse Trendelenburg position, again, head up, feet down, and we look at the deep system. Reflux in the deep system is usually more than 1 second, and reflux in the superficial system or perforators is usually anything more than 0.5 seconds. And documentation is important. Personally, I think about massive reflux as something that we need to treat. Simple reflux, 0.5 seconds, plus or minus on somebody who doesn't have a lot of symptoms. Well, perhaps we're better off just treating with maximal medical therapy, which is certainly the standard of care. Again, this is an example on a patient with reflux. We compress the vein, there's flow, flow goes above the baseline, and we're able to measure the time it takes for it to return back to baseline. And this is important. Again, superficial reflux more than 0.5 seconds, deep reflux more than 1 second. Again, this is another example. Patient is breathing. Here we didn't do augmentation with compression, we did with Valsalva, and you get the increase in flow. Here, on the other hand, there's flow. We compress the calf and we get the reversal of flow. Again, augmentation with compression, and then we get the reversal of flow and return to baseline. Perforators is very important. So what is a perforator? Let me get my cursor to come to my screen. Here we go. Perforator is a connector, in a way, between the deep system and the superficial system, and you see that sort of a vein that courses or connects both. Blood flow has to flow from the superficial system to the deep system. So from the outside in and from the inside, from the bottom up. So if your perforator is dilated more than 3.5 millimeters and it has reflux in it, then we call that a incompetent perforator. And here's one example. Here's a perforator. And again, what's a perforator? It's a vein that connects the deep vein to the superficial vein, and it crosses the fascia. And the fascia is that nice, bright, shiny, hyperechoic white line. Okay? This is one of the examples. This is a perforator coursing through a fascia, connecting the superficial to the deep system. Again, we see the fascia here. There's a deep system, superficial system, and there's our perforator. And again, on the reflux studies, as we showed earlier, we want to document patency of the vessels. We want to document the time for reflux and whether the veins are obstructed or not, and also the size. The diameter is very important. So 3 key elements of the venous exam. Venous compressibility, you do that in 2D. Color flow, waveforms, you want to look for spontaneity, phasicity. We want to see if venous flow does augment proximal distally with augmentation. You want to see if the flow is pulsatile or not, or arterialized, and we also want to document the patency of the vein. Let's talk a little bit about central venous disease. There's thoracic outlet disease, and this is the subclavian vein. It's usually subject to compression at various elements within the thoracic outlet, which can include, let me get my cursor. If I can get my, there we go, where's the cursor? It can be compressed between the first rib and clavicle junction, or underneath the pectoralis minor, as in pectoralis minor syndrome, as it joins the shoulder. And we discussed this earlier in one of those examples where we see continuous waveforms on the venous study in the subclavian, as we see here. So this is on the more proximal subclavian. You see sort of a phasic flow, but then in the thoracic outlet or lateral to the clavicle, we see how the subclavian axillary vein, the flow is more continuous, suggestive of central obstruction. This is one example. For example, is a patient who came in with a DVT in the subclavian vein. And here what we're doing is we're crossing the area with a wire to be able to do thrombolysis. And this here is after we've performed thrombolysis. And you see that there's still an area of compression, almost a thumbprint sitting right here. And that's where the compression exists. But we're able to remove the thrombus to get some forward flow. This patient will eventually require likely rib resection. May-Thurner syndrome entails compression of the left iliac vein by the right common iliac artery against the L5 lumbar vertebra. And like the examples I provided earlier, you would see phasic flow on the right side and potentially non-phasic flow on the left side in worst case scenarios if the compression is tight. And this is what a compression will look like. This is an MRV. But why are we talking about this? Why? Because we can do intravascular ultrasounds. And here you see the right common iliac artery compressing up here the left common iliac vein, and this is our vascular ultrasound, intravascular ultrasound. So we puncture the femoral vein, go up, and we're able to image and really identify any webbing or any area of stenosis and take some accurate measurements of the vein. So in general, you need to follow a protocol. You do it the same way every time. Why? Because it's going to become almost a reflex action when you do your ultrasound. Number two is going to provide you consistent images, consistent reads, and the physicians or those who are reading your tests to be able to make a clinical decision will rely on your assessments more readily. And then obtain images in 2D, obtain color images, and flow waveforms to characterize your findings. Especially when abnormalities or pathologies identify, you may want to obtain additional images to really provide an adequate picture, because doing your ultrasounds is extremely important. This concludes our session for today. I will wait and see if we have any questions that have been sent to us. And again, if you want to join by web, go to paulev.com, enter DeBakey, and respond to the activity. And if you're joining us by text, enter DeBakey to 37607 and text in your question or your message. And again, for those who want to look at this lecture again, you can also find us on YouTube on the Methodist DeBakey page. For those who missed the session today, of course, this will be present on YouTube for us to, for those interested to look and watch later. Again, if there are any topics you may be interested in hearing about for our future sessions, please also send us a message, reach us for our various media means, and we'll try to accommodate any interesting topics that you wish us to discuss. Seems that everybody feels comfortable and great doing venous ultrasounds. We have no questions so far. Well, meanwhile, let's talk about this. So with COVID, performing ultrasounds during the COVID pandemic has been a little bit more cumbersome because of the technical aspects. You're going to a room, everything has to be clean, sterilized. Sometimes the patients are extremely sick on a rotor rest bed, etc. So what has happened is some of the studies have been expedited, where instead of obtaining all the images that we need, we obtain fewer images of the various segments for documentation. All the segments are being looked at, but what's being saved, it's a much shorter study. Because of the technical aspects involved. Sometimes patients are on ECMO and it becomes a little bit difficult to perform the study, and also the limitations of the staff accessing the patient rooms, who sometimes are maybe slightly crowded with various equipment and machines. Again, with the COVID pandemic, I think there has been an increase in venous thrombosis. Almost as it mimics almost the number of DVTs mimics the increase in COVID cases, and this is something that that's going to continue, in the sense that those patients will have to be followed carefully as we look for recanalization and we plan any therapeutic interventions, as in timing for anticoagulation, how long to keep the patient on anticoagulation, what dose, and so on. So ultrasound really helps us a lot in this instance. Well, it seems that there are no questions so far. It's been a real pleasure being here with you today. And if you have any other topics you wish us to discuss, please let us know. With this, we will conclude our venous upper and lower extremity duplex ultrasound master class. Thank you so much.